So we've just finished a very lively debate session on looking at the adolescent and young adult lymphoma population, those with high-grade lymphomas, specifically Burkitt's lymphoma and diffuse large B-cell lymphoma. The debate is, do we treat these patients with more of a pediatric-focused regimen or an adult-focused regimen? This is an area clearly of unmet need. There is still a lot we don't know about this patient population in the terms of biology, and this is a very challenging population to treat in many instances. So we do see this as a real priority area for research focus going forward. So with that, we invited two very distinguished lymphoma doctors in the field, Dr. Tom Gross from the National Cancer Institute, who is a pediatric oncologist, and Dr. Kieron Dunleavy, also from the National Cancer Institutes, who is a medical oncologist. So with that, I'm going to pose 4 challenging questions to my esteemed colleagues, and I will ask each one to respond, and then we can decide who is the winner. So question number 1 is, should patients or AYA patients with Burkitt's lymphoma or diffuse large B-cell lymphoma be treated with the same regimen, and is this why kids do better? So I've posed this question first to Dr. Gross.
Well, one of the issues is that historically we've always combined large cell lymphoma patients with the Burkitt's. In pediatrics, we see much more Burkitt lymphoma than large cell. The most current results are outstanding with regimens such that the cure rates are about 95%. It's unclear, though, since there's very few patients in the AYA group that are enrolled on these studies, if it is best for them, but that is what we've done traditionally, and with the very, very good results, it's challenging for us to try to think of doing something different that may not be quite as effective.
And just to explain the numbers in your groups of what your successes are. And
so for the Burkitt's lymphoma, even in the most advanced stage disease, the cure rates are about 95%. It really doesn't matter now. We do a little bit of different types of therapy, so the less aggressive get a little less therapy but the outcomes are about 95%. On the other hand, when you look, it's about 70% will be Burkitt's, with only 30% being large B-cell. And when you look at the 15 to 18 or 21-year-olds, which are really the young adults and adolescents, they only represent 10% or less of all patients enrolled in our trials. So it's difficult to make definitive conclusions on the efficacy of them. The analysis that we have done have not been able to show any difference, though, between the younger kids and the adolescents and young adults in our trials, though the numbers are small to show any potentially small differences.
So your answer is yes, they should be treated with the same regimen. Am I correct?
Yes. The big concern is that those results are outstanding. The caveat is that the short-term toxicities are significant. All the patients require hospitalization with significant side effects that demand very aggressive management. And so this is something that is the price to pay, so to speak, with these good results, but very aggressive therapies.
And the medical oncologists will tell you that the pediatricians give far too much high-dose methotrexate. How do you respond to that, given these great results?
I think that there is a debate that is a very reasonable debate. The biology and the rationale for giving the high doses of methotrexate is not there. It's not strong. But we've done that traditionally and seen results improve by doing that. And the other problem is that if these patients don't respond to these therapies or it recurs, we do not salvage them at a very high rate at all, less than 10%. So it's difficult for pediatricians to back off on giving these high doses of methotrexate since we are very concerned about potentially undertreating a patient and risking a relapse.
All right, Dr. Dunleavy, the answer from the pediatric side was yes, they should be treated with both regimens. What's your response, and do you think this is why kids do better?
Yeah, so I would answer the second question first. I think kids do better for two major reasons. Number one, because they have better tumor biology. If you look at the biology of diffuse large B-cell lymphoma, as people age, it becomes genetically more complex. So, for example, the proportion of cases that are of the activated B-cell subtype increases as people age, and we rarely see this subtype in pediatric and adolescent populations. And if you look at other abnormalities like MYC and BCL2 and mutations and aberrations, these are much more common in people as they get older. The second big reason why I think pediatric populations do much better is that they tolerate treatment well. One of the big challenges in treating particularly Burkitt lymphoma is that it's a disease that's characterized by a very high tumor proliferation rate, and it requires strategies that overcome that. And these strategies are associated with a lot of toxicity for the most part. So that's a challenge for adults, particularly older adults, but also for adults within this AYA population.
So your answer to the question should be they should be treated with the same regimen?
Well, the standard regimen in adults with diffuse large B-cell lymphoma is R-CHOP, and R-CHOP is not very effective in Burkitt lymphoma. It doesn't work well in tumors with a high proliferation. So if you're talking about R-CHOP, the answer is no. But on the other side, the treatments that are very effective in Burkitt lymphoma are associated with very high toxicity, and it's hard to say that they should be standard, and they certainly should not be standard for diffuse large B-cell lymphoma. So we have an ongoing multi-center study using dose-adjusted EPOCH-R, which is a regimen of intermediate intensity. And so far it works very well in Burkitt lymphoma, and it's also effective in diffuse large B-cell lymphoma. So I think if you are going to treat them both with the same regimen, then you should use that regimen because it works well in both and it is well tolerated in both adults and children.
We talked a bit about the concern that pediatric doctors and adult medical oncologists are not always talking about apples and apples. It can be apples and oranges, and the pediatric community use this group ABC system, and the adult oncologists use different staging systems. So can you speak a bit to that and how you're going to try and look at trying to speak the same language so we can compare studies?
Yeah, so I think historically, pediatricians and adults have approached lymphomas in a very different way, and their classifications and staging systems that they've used have been different. And I think that it's really critical that we all talk the same language, and in terms of using risk categories, yes, that we look at our adult patients and look at them in the context of the risk categories that the pediatricians have defined over time.
So, and then the last question that we're going to really address is the PMBL patients, because I think they're a very select group of patients. They actually really fit the AYA population in particular. So I would like first to ask Dr. Dunleavy to talk about whether he thinks all AYA patients with PMBL should be treated with dose-adjusted EPOCH-R. So
primary mediastinal B-cell lymphoma is considered to be a subtype of diffuse large B-cell lymphoma, but it really is very distinct. And if you look at the other subtypes of large cell lymphoma, and if you do gene expression profiling, it's really different, and it has a lot more in common with classic Hodgkin lymphoma. And I think that's important in terms of how we think about it and how it benefits from dose intensity. It's a pretty rare disease, so there are no randomized studies that have compared different types of treatments. But we did a study at the NCI, and we combined the experience with Stanford. They had a retrospective experience. We did a prospective study, and we now have treated 92 patients with the regimen, and the event-free survival is 90%. That's without radiation treatment, and that's critical. And this patient population, they're young, they have a highly curable disease, so if you can avoid mediastinal radiation, you certainly want to do that, because if you look at the incidence of secondary cancers after 10 years, especially in females, 20% of patients can develop breast cancer. So taking radiation out of the equation is very important. So I would say right now, yes, the results are excellent. There's not been a randomized study, but I think we have a big N. So I would recommend using dose-adjusted EPOCH-R for newly diagnosed patients with this disease.
Okay, Dr. Dunleavy says yes. What do you say, Dr. Gross?
The answer is maybe.
And why do you say that?
Historically, this group of patients has done worse on pediatric regimens, worse than Burkitt's and worse than other large cell lymphoma. We, in an international setting, tried to reproduce the fantastic results that Kieron and his colleagues have had with this regimen at the NCI. Unfortunately, in a small series of only about 40 patients, we were not able to reproduce those great results. And in fact, the results were very much the same as anything else we've tried in the past. I think part of that problem is just some of the numbers game with small numbers, as is other groups such as the German pediatric group have used this regimen and had results that are much closer to what has been shown at the NCI. I think there is a difference of opinion in pediatricians about what is the best regimen to use in this disease. My opinion is that this regimen is well tolerated. Putting together all the data is as good or better than anything else that we have used. And I think this is a disease that truly is an adolescent and young adult. And to be able to study it better, we need to be using the same definitions, the same treatments. And this is a great opportunity to do that using this regimen as a backbone to look at new and potentially even more effective therapies.
And are you talking about partnering with adult cooperative groups? This is
correct. So I think if we're going to make advances in the adolescent and young adult population, really it comes down to very simple differences. As Kieron said, in Burkitt's lymphoma, I don't think the disease is that much different, but the ability of patients to tolerate the therapies is considerably different. And so what is best between the 15 and 35 years of age? Large cell, the biology is really the issue. The disease we see in young kids less than 15 is probably much more different, more aggressive, and might benefit from the pediatric regimens. It's certainly different than the disease you see in 15, 60-year-olds. The question is, what's the difference between a 15-year-old and a 35-year-old? And that we need to understand and to work together, the pediatric cooperative groups and the adult cooperative groups, to really understand that issue. I think a great example is the large cell. In my personal experience, I've talked to several parents and patients about that have large cell what's best to do, and go over the pediatric regimen, which is a lot of acute toxicity but potentially less long-term side effects. The adult approach, which is outpatient, maybe potentially more side effects. Every one of the parents wants the pediatric regimen because they're worried about the long term of their daughter or son. Every one of the patients, the kids, wanted the outpatient therapy and received it. And I think that really sums up what we're talking about with AYA, is that it's a complex group, not only from a biology standpoint, but also from some social and behavioral issues as well.
So I think in the last 2 minutes, I'd just like to talk about, what we can do going forward. And, obviously we have some great results out there. What is the possibility of incorporating novel agents into these regimens, and what can we do, if anything, for the relapse population? So I'll ask Dr. Gross to respond first, and then Dr. Dunleavy.
Yeah, unfortunately, if we stay with just pediatrics, we have a big problem because we have fewer number of patients. The outcome is so good, it's almost impossible to improve on our upfront results, and because the results are so good, it leaves us very few relapse patients. If we're going to make progress, I think we have to start working together with our adult colleagues, and I think focusing on the older kids, and because the biology is probably more similar to a 15-year-old and a 30-year-old than a 15-year-old and a 5-year-old. And so I think that's really where we have to go forward, is to partner, because we just don't have enough patients where things are at now.
Do you want to talk about, Dr. Dunleavy, some of those potential novel agents that we could explore in that AYA population, bridging
exactly.
this
And
age
I
group?
totally agree with Tom. I think that historically the distinction between pediatric people and adult people has not really been very helpful for this group of patients with AYA lymphomas. And it's really critical that we work together in the future and really define them as an entity in terms of moving forward. There are lots of pathways and potentially exciting new agents for this group of patients, particularly for patients with primary mediastinal lymphoma and for patients with Burkitt lymphoma. We have heard a lot of this meeting about immune checkpoint inhibitors, and there are ongoing trials in patients with relapsed primary mediastinal lymphoma in adults with immune checkpoint inhibitors, and the results are very promising so far. So that's an example of a strategy I think that might be very interesting in mediastinal lymphomas. In Burkitt lymphoma, there are a lot of targets that have been identified over the past few years. I think that PI3 kinase inhibition might be an interesting strategy. But the challenge with Burkitt is that we're doing so well, the cure rate is so high that putting patients on clinical trials is a real challenge. And when patients relapse, they really don't have a lot of time, I think, to go on a clinical trial. But I think that there is a lot of excitement in the future, and I think the critical thing is that we work together and that we understand the biology of the tumors that we're dealing with as we develop new agents and new drugs and new strategies.
So thank you, both of you, very much. I think to summarize, there's no winner. I think it's clear that there's certainly controversy in the field, but I do think that there is a will on both sides. If it is a side issue between pediatric oncologists and medical oncologists to, in particular, come together and really try and answer these controversial questions about the management of our AYA population. So I'm hoping that if we do this debate in the next 5 years, for example, that there may be less controversies and we may all be a bit better aligned in how our paths are going forward for the management of these patients. So thank you very much.